Hello, my name is Matthew Moake, and together with my colleague Julie Leviter, today we're going to talk about gastric ultrasound. The goals and objectives for today's talk are to review the indications and probe selection to perform this exam, touch on the technique for image acquisition, review the normal anatomy, pathology and abnormal findings, review a few pearls and pitfalls, and discuss some illustrative cases that you could use this technique for. The indications for performing gastric ultrasound that we are going to discuss today include the qualitative and quantitative evaluation of gastric content. This can be useful in two main arenas. The first is as an adjunct for anesthesia aspiration risk assessment, and the second is if you are in the gastroenterology field to use this to evaluate for gastric emptying and motility. The other indication we're going to discuss today is the evaluation for gastric foreign bodies. When performing this exam, you can use a couple of different probes. I typically find myself using the curvilinear transducer to initiate the exam. This is because the wide field of view and depth of visualization allows you to define well the gastric anatomy and size. Typically, we'll use the abdominal settings. You want to have your depth set deep enough to be able to visualize the aorta in a sagittal subxiphoid view. And when evaluating for foreign bodies and using the supine left upper quadrant view, you want to make sure your depth is deep enough to be able to visualize the stomach in the far field. For thinner patients, often transition from the curvilinear to the linear transducer. The linear transducer's higher frequency allows optimized gastric content visualization. Typically, we use this under the small parts setting, and a depth again to visualize the aorta in the sagittal subxiphoid view when assessing for gastric content and volume. First, we're going to review the techniques for evaluation of gastric content and emptying. When performing this exam, again, you'll use the linear or curvilinear probe based on your patient's habitus. Start with the patient in supine positioning. You want to place your probe in the midline sagittal axis below the xiphoid. Here, you'll identify the gastric antrum at the level of the descending aorta. Once there, you can evaluate the qualitative gastric content, meaning is that content empty, liquid, or solid. You can repeat this exact same evaluation after you have your patient roll over to the right lateral decubitus position. And then for patients you want to do a quantitative evaluation, you can measure the antral cross-sectional area in the right lateral decubitus position to quantify gastric volume. Here we have our patient in both supine and right lateral decubitus position. The transducer is placed again in the sagittal axis just below the xiphoid process. In the supine position, when you look at the way gastric content will lay out, here we have our stomach overlaid onto our patient. If there's air in the stomach, that air is going to rise to the least dependent part of the stomach. And with that, you're going to have your gastric content is both going to be below air, which can shroud it, as well as it's going to make the content distributed out over the width of the stomach, which can make that content look a little bit less. By rotating your patient over into right lateral decubitus position as shown on the right, that stomach content then tends to act like a funnel towards the antrum. Air will rise to the least dependent area, which in this case is going to be away from the antrum, and that content will funnel down, allowing you to get better visualization of gastric content. Here we have our anatomy at the level of the gastric antrum using the curvilinear probe. You can see we have our liver, our antrum, and our aorta in the far field. On the right, we have a video looking at this same area, and this gives you a sense of how this occurs with patients breathing, with the effects of peristalsis going through the stomach itself, and how those content can change with those movements. Here we have that same view with the patient using the linear probe. Again, our anatomy, liver in the near field, antrum below the liver, and the aorta in the far field. And on the right here, we have a video that demonstrates this again in moving, going from what initially looks like an empty stomach to clearly having some content in it as the patient is breathing and the stomach is peristaltic. In order to perform a qualitative evaluation of gastric content, you want to be able to break your content down into whether it's empty, liquid, or solid, as shown here. On the left, we have an empty stomach where the walls of the stomach are collapsed and there's really nothing in it, and you'd want to visualize this with the video to make sure that nothing actually changes in that visualization. In the middle view, we have a picture of clear liquid within the gastric antrum, that black hypoechoic fluid sitting within the walls of the stomach. And on the right, we have a view of solid content, hyperechoic, mixed echogenicity, and in this case there's also some air entrained in the stomach, giving you some dirty shadowing that is obscuring the aorta in the far field. Here we have those same findings seen with the linear probe. On the left, again, an empty stomach with the gastric walls touching each other. In the middle, we have clear liquid content with a few admixed air bubbles. Note, in this middle image in particular, you get a really excellent view with the linear probe of the gastric walls. The gastric walls are made up of variegating hyperechoic and hypoechoic structural layers. And on the right, we have our solid content, again, this hyperechoic mixed echogenicity content. As mentioned previously, air within the stomach or any other component of the bowel will typically appear as a hyperechoic bright signal, typically going to be in the near field or least dependent part of the stomach since air will rise, and providing what we call dirty shadowing, extending from that bright hyperechoic signal down into the far field, often obscuring structures posteriorly. This you can see here with both the curvilinear and linear probe on the right. Looking very quickly at the effects of position when you're looking at gastric content. So here we have the exact same patient imaged within minutes of itself in the supine on the left and right lateral decubitus position on the right. You can get a sense here on the left, in the supine position, the gastric antrum appears fairly small. There is some hyperechoic content within the antrum, a little bit of dirt or shadowing occurring. But then on the right here, you can see there's a much larger antrum, lots of hyperechoic signal in this dirty shadowing, and it's really hard to get a general sense of just how large this antrum is because of that air that's in the stomach and its shadowing. And here we have videos of these two. Again, on the left, supine, small gastric antrum, you get a pretty good sense of content as well as that posterior gastric wall. And on the right, much larger gastric content, hard to visualize that posterior wall due to that air shadow. So, now that you're able to look and identify the stomach and look at the content that's in there, what do you do with this information? There are a number of studies out of the anesthesia arena looking to assess the ability of point-of-care gastric ultrasound to quantify gastric content and put that into an algorithm to determine aspiration risk in the general anesthesia venue. There are two main groups that have worked on this. There's the Perlis group out of Canada and then the Bouvet group out of France, both of whom have done a lot of work in this field to both develop the models that we use today as well as to look at the clinical applications. From these studies, the model proposed by the Perlis group seems to be the one that has taken the most hold and is the one that I personally use. When performing this evaluation, you're going to start with your patient in the supine position. From the supine position, if you see solid content, that patient is considered to be high risk from an anesthesia perspective. If you see liquid content within the supine evaluation, this is also considered to be suggestive high risk, with the argument that there's enough liquid content there to present a serious aspiration risk. In your supine evaluation, if you have an empty stomach, you then proceed to the evaluation of the patient in the right lateral decubitus position. In the right lateral decubitus position, if you see solid content, you're once again considered to be high risk. If you see liquid content at this point, you're considered to be suggestive of low risk on a qualitative scale, with the argument that there's small enough volume there that it's not going to present a significant aspiration risk. And if you're considered to be emptied, you're considered to be low risk. In both cases where you have liquid content in the supine as well as right lateral decubitus position, you can also perform a quantitative evaluation by measuring gastric volume. That gastric volume is measured using the measurement of antral cross-sectional area shown here. You again get your view of the antrum with the aorta in the far field, and you can use either your machine's tracing tool to outline the outer edge of the gastric antrum, or you can use the machine's calipers to measure an AP and craniocaudal dimension as shown on the left, and then use the equation shown below to calculate a antral cross-sectional area. From there, again, you take those liquid content, do this volume determination, and with your cross-sectional area, you plug your cross-sectional area into one of two equations that have been determined, one for pediatrics and one for adults as shown here. With those equations, you generate a gastric volume, and then based on the volume, that patient could be now qualitatively broken down into being either suggestive of low risk or suggestive of high risk. You'll note that the volume cutoffs here have a range ranging between 0.8 to 1.5 mLs per kilogram within the literature. There still remains debate as to what is considered to be a, quote, safe amount of content to have in the stomach and what is high enough to pose a significant aspiration risk. Putting those collective evaluations together, you can do your qualitative exam. Based on the qualitative exam, if you are empty, you're considered to be low risk. If you have liquid content only in the right lateral decubitus position, you're considered to be grade 1 or suggestive low risk. If you have liquid content in the supine position, you are suggested of high risk or grade 2. And if you have solid content in either evaluation, you are considered to be high risk. And then for grades 1 and 2, those suggestive of low risk or suggestive high risk groups, you can do your volume determination, and based on your volume cutoff, you can then break that down quantitatively into being suggestive of high or low risk. Some pearls and pitfalls when performing this exam. As in all ultrasound studies, obesity limits your imaging quality and your ability to discriminate gastric content. Air within the stomach or overlying bowel obscures the view of deeper content, be that seeing the stomach itself or seeing deeper content within the stomach. To try to work with that, you can use variations in probe pressure as you do with any other abdominal application. You can try positioning your patient in the right lateral decubitus position to redistribute air. That may help you. You may also find that it hurts you. You can also repeat your imaging to allow for air to pass. It can be challenging to discriminate small amounts of solid content from admixed air. That again can be helped by, once again, repeating your imaging, or in cases where it's amenable, using your linear transducer for increased resolution. Despite some of these limitations, most studies have reported the ability to discriminate gastric content in greater than 90% of patients that have been evaluated. And smaller studies looking at the inter and interrelator observability have shown high reliability within these, and they've also shown learning curves for this modality to be similar to other POCUS modalities. Now, having reviewed the technique for this evaluation, let's look at its clinical application. The clinical application for this technique is centered around the fact that gastric content is variable. If you recall back at these images we showed previously, looking at the empty, liquid, and solid content as visualized with a linear probe, what's interesting about these images is that these three images are from siblings presenting to the pediatric emergency department all of whom had eaten the quote-unquote same thing, with a fasting time of 9 hours for solids and 2.5 hours for clears. Despite this, the sibling on the left has a very empty stomach and considered to be low risk by the anesthesia models. The sibling on the right has thick solid content and would be considered to be high risk. And the patient in the middle is in that gray area that, depending on the positioning that you were evaluating or the volume quantification you performed, they'd be either suggestive of low risk or suggestive of high risk. This is where gastric ultrasound becomes valuable, is the ability to look at gastric content and define what is actually in the stomach as opposed to relying on the historic fasting times used for NPO or nil-per-os classification. So let's look at these in practice. Say we have two siblings, 8-year-old brother and 6-year-old sister, who happen to be climbing a tree while on vacation. Inevitably, as siblings do, they tend to squabble, and because they're in the tree, they fall, and gravity always wins, and they result in injuries. The 6-year-old sister ends up with a classic both bone forearm fracture. Bread and butter pediatric emergency medicine case, something that's going to be treated with a procedural sedation with the orthopedic colleagues, straightened, put into a cast, and sent home. 8-year-old brother, on the other hand, is not so lucky, and he suffers a transverse fracture of the mid-femur and is going to require operative repair. Our 6-year-old female with the both bone forearm fracture is likely going to undergo a pediatric procedural sedation there in the emergency department. In this context, both Dr. Leviter and I have looked at the gastric content of these pediatric patients, and despite these studies being done at very different centers, had very similar results. In Dr. Leviter's study, she had 107 patients who had a 69% high-risk content with a median fasting time of 5.8 hours. And in my own study, we had 93 pediatric patients with high-risk content and 79% with a median fasting time of 6.25 hours. Between our two studies, there were no cases of aspiration within these pediatric procedural sedation patients. However, important to note, neither of these studies was powered for this outcome, and the incidence of pediatric procedural sedation aspiration is exceedingly rare. In fact, there's never been a reported case of a ketamine sedation resulting in aspiration within a pediatric emergency department. The findings of these two studies, in the context of the much larger data set suggesting that pediatric procedural sedation is safe, would suggest that our standard of care pediatric procedural sedation is probably occurring in patients who have high-risk gastric content by ultrasound, and that despite this content, these sedations do in fact end up being safe. Knowing this, there's likely little indication to perform gastric ultrasound in your pediatric procedural sedation patients, except maybe in a few select situations where you have high-risk patients are performing procedures that are going to be higher risk from an aspiration standpoint, such as those involving the upper airway, or perhaps when considering sedative medications such as propofol that naturally lower your upper airway tone and may be more prone to aspiration. In contrast, within the general anesthesia field, where cases are longer, medication use is different, and airway manipulation is almost always involved, being able to use ultrasound to evaluate for gastric content can have big implications upon the planning of anesthesia approach as well as timing. There have now been a number of studies within the anesthesia arena using gastric ultrasound to assess the stomach contents of a variety of patients, including both adult and pediatrics, undergoing elective surgeries as well as urgent and emergent surgeries. What this data has shown is that the majority of patients in both adults and pediatrics who are undergoing elective surgical procedures and who meet fasting guidelines tend to have empty or safe stomachs. In contrast, those patients undergoing urgent or emergent surgeries frequently have gastric content that is considered to be high risk, despite the fact that in many of those cases, the fasting times of those patients were well in excess of the times typically required to be considered fasting for elective surgeries. In one study, 56% of 250 adult patients undergoing emergency surgery had this high-risk content with a median fasting time of 18 hours. And in the pediatric population, 46% of non-elective pediatric surgery patients were found to have gastric content above the risk threshold with a median fasting time of 11 hours. So, back to our 8-year-old male who's got a femur fracture and needs to go to the operating room. Say we do our gastric ultrasound evaluation, and this is what we see in both the supine and right lateral decubitus positions. This is a nice empty stomach. This would suggest that this patient is low risk from a gastric aspiration standpoint and can likely go ahead and proceed with anesthesia using whatever route is chosen, including a mask induction and standard intubation. In contrast, if instead we were to get this upon our evaluation, here we would see an enlarged antrum that has hyperechoic and heterogeneous content suggestive of solid material, which within our algorithm would point to this patient being high risk for aspiration. You could then integrate this information into the plan for anesthesia, be that both the timing of when to proceed as well as which airway and induction techniques to proceed with. For a femur fracture patient, you have a patient who has an urgent or emergent indication for surgery. This may be a patient that you go ahead and proceed with surgery, but instead of doing a mask induction, proceed with an RSI technique. Conversely, if this is an elective surgery patient, these findings would suggest they likely have not been compliant with their fasting guidelines, and you might choose to cancel the case. Alternatively, in both situations, you might instead delay the case and perform serial evaluations to see if this gastric content clears. Here is an example of performing one of those serial evaluations. So at our time 0, we have our enlarged antrum with mixed heterogeneous gastric content. 2 hours later, we perform the same evaluation, and here you can see that the gastric antrum is overall smaller. You can now largely define the craniocaudal extent of the antrum. You still have a good bit of solid content with some air in it that is shrouding the posterior wall, but overall things seem smaller. 2 hours later, the gastric antrum is even smaller. Now all of the air that was previously seen has managed to make its way out, and you can define the posterior wall. There is still, however, solid content within gastric antrum. And then 2 hours later, you get this image showing an empty gastric antrum and can now proceed with the surgery using a mask induction or more relaxed technique. Here is another example of a serial evaluation for a different patient. In this case, at time 0, we once again had an enlarged gastric antrum with this heterogeneous solid content. 2 hours later, the antrum looked overall smaller, content seemed like it was clearing. However, 2 hours after that, as opposed to our last patient where we saw a complete emptying of gastric content, in this case, the gastric antrum suddenly seemed to be much larger and have once again this return of heterogeneous hyperechoic content. In this case, the patient had a little bit of a snicker on their face. You noted a snack bag in the corner, and they had Cheeto fingers, and you're able to detect the patient had been non-compliant with their fasting in this interval, at which point you can decide either to cancel the case or further delay it as necessary. This same serial evaluation of gastric content could also be useful in the field of gastroenterology. You can imagine giving your patient a defined amount to eat or drink, performing an initial evaluation, and then doing evaluation serially as a way to monitor and track gastric empty-in time. Next, we're going to change gears a little bit and look at the use of point-of-care ultrasound for the evaluation of gastric foreign body. As we all know, both children and adults, unfortunately, tend to put things in their mouth that don't often belong there, and in some cases, some of those items, whether they be intentionally or not, end up swallowed and entering the GI tract. In some cases, like the image on the right, those items are radiopaque, such as the coin shown here. However, in many cases, these items are not radiopaque, and ultrasound can provide a particularly useful tool for evaluation of these foreign bodies. For this evaluation, once again, we're going to use either linear or curvilinear transducer based on the patient habitus. There are a variety of ways to go about the evaluation of gastric foreign bodies. Ultimately, you want to have an organized approach to be able to fan through the stomach. I personally like to start my evaluation the same way I start my gastric content evaluation as we covered, starting at the gastric antrum in the sagittal plane. From there, I will fan the probe upwards and towards the left shoulder with rotating counterclockwise as I go to match the curvature of the gastric body and fundus. If I don't see what I'm looking for during that supine evaluation, I will roll my patient to right lateral decubitus position, similar to our gastric content and volume evaluation, in order to channel gastric content towards the gastric antrum and repeat that same evaluation. And then lastly, if I haven't seen anything within those positions, I'll put my patient back in the supine position and then perform a coronal approach in the left upper quadrant, similar to your fast view, to try to look from the bottom of the stomach up in case there may be air that's obscuring from the top down approach. Here we once again have our patient lying in the supine position with the probe in the sagittal subxiphoid location, which should be located along the gastric antrum. From here, if we rotate our probe in a counterclockwise fashion and slide it up towards the gastric body and fundus, we can hopefully assess the full length of the stomach, and then you can repeat that evaluation in more of a long axis as well. Again, showing our gastric content in this position, it's going to be flattened out, and if there's air, it'll be towards the least dependent part of the stomach. And if you come in with your fast approach and aim anterior, you may very well be able to look at that gastric content from the inferior portion and look behind the air that is otherwise being shrouded when you look from the anterior approach. Here we have once again the anatomy at the gastric antrum with the liver and aorta in view at that level, using both the curvilinear and linear probe on the right. On the left with our curvilinear probe, as we go ahead and fan there from the antrum heading up towards the body and fundus of the stomach, you can see that small antrum going and progressing, getting larger, and eventually here we end in the body of the stomach with this very large hyperechoic air stripe that's shrouding out the imaging behind it. Similar on the right, we have our linear probe with a very small collapsed antrum shown here, and as we start to fan towards the body of the stomach, you can see that little antrum now starts distending out into the larger body of the stomach, and we have this mixed heterogeneous content within the body of the stomach. Two more views now of the gastric body. In this case, we're looking more in kind of outright transverse views of the stomach. On the left, once again, we have our liver, antrum, and the body of the stomach shown here. This, in fact, is a patient who's undergoing a pyloric stenosis evaluation, so these images may look familiar to those of you who do that evaluation. And you can see the antrum heading to the pylorus on the left, and then the body heading towards the fundus of the stomach. As you come across, there's some hyperechoic air sitting in the least dependent area of the stomach here with a little bit of shadowing, but not enough to obscure all the content behind it. And on the right, we have a patient. In this case, this was a young child who had an x-ray that was concerning for a mass due to absence of air in the left upper quadrant. We performed a point-of-care ultrasound to define what that mass was. We have liver, the very enlarged body of the stomach. In this case, our mass was just a fluid-filled stomach, and spleen in the far field. And you can see this largely fluid-filled stomach with a little bit of heterogeneous content sitting within that. Looking at that left upper quadrant sort of bottom-up view, in this case, this is a view that should be pretty familiar to you if you're used to doing the FAST evaluation. We have our spleen and kidney visible in a coronal plane. As many of you know, if you do the FAST evaluation, viewing fluid in the stomach can be a source for false positive FASTs if you're angled too far anteriorly. In this case, we can see here on the left, we've got the stomach sitting there with this liquid content and this chunk of thicker, kind of more mixed solid content floating around in it. And on the right, similarly, we've got our liquid content. In this case, we've got a bunch of admixed air bubbles. And what you note as we fan through intermittently, as you come up more anterior, you see this bright wave of hyperechoic signal coming in. That's looking up and seeing the air from the bottom up. And in this case, since you're below, you're seeing content below the air, and the air is shrouding what would be the anterior fields. When looking for foreign bodies, unfortunately, our findings are going to be pretty variable depending on the foreign body. Inorganic material tends to be hyperechoic with shadowing or reverberation artifacts, similar to foreign bodies that we're used to looking for in the soft tissues. In contrast, organic material often does not have shadowing or reverberation artifact. If you remember the images we showed in the first half of our lecture, where we showed that thick, solid content, if you think about it, really any food you eat could be considered a foreign body, and thus you may see something that looks just like a standard full stomach. The shape of your foreign body is going to be highly dependent on the orientation of that foreign body within the stomach. With that, due to the fact that your foreign body is going to be sitting within the liquid of the stomach, and that content is moving through peristalsis to the stomach, the appearance of that foreign body is going to be changing over time. That variability of foreign bodies as seen within the fluid of the stomach is something that may be familiar to you. For those of us who do a lot of ultrasound teaching, we've all probably buried a foreign body in a water bath or some other gel medium in order to teach our learners. In this case, on the left, we've got an image of a foreign body sitting in a large water bath. You can get a sense there's a hypoechoic structure with shadowing behind it sitting at the bottom of this water bath. It's hard to kind of tell what the structure actually is. However, you take it on a separate view. Here you get a sense now we're getting more of a long axis to this picture. And when you see what the object actually is, you can get a sense that it's pretty easy to recognize it in the image on the right, but on the image on the left, it's a little less clear. And so your foreign body visualization is also going to be dependent on how cleanly you get that sort of view. Pearls and pitfalls when performing this evaluation are very similar to that when performing the evaluation for gastric content. Obesity is going to limit your imaging quality and gastric content discrimination. Air within the stomach or overlying bowel is going to obscure structures. Again, you can try to work with that using probe pressure, right lateral decubitus positioning, repeat imaging to allow air to pass, or using that supine, kind of fast left upper quadrant bottom up view. It can be challenging to discriminate small hyperechoic foreign bodies from gastric content or air. And once again, not all foreign bodies produce a shadowing or reverberation artifact, which can make them really challenging to discriminate from other ingested content such as food. There's not much in the way of great literature looking at the performance specs for ultrasound to evaluate foreign bodies within the stomach. This is a recent case report that looked in 14 studies, totaling 52 foreign bodies identified with point-of-care ultrasound through the GI tract. It describes 11 of those in the stomach, which is primarily inorganic material, the smallest dimension of which was 2 millimeters. Again, however, this study was too small to be able to report any form of sensitivity or specificity analysis. Now, let's go ahead and look at a few clinical cases involving foreign body ingestion. In this first case, we have a 5-year-old male who reported swallowing a small troll figurine. We performed our evaluation initially around the level of the antrum with using linear probe. Here in this first image, you start to get a sense there is this hyperechoic object with posterior shadowing falling behind it. As we pan through the antrum and watch this object a little bit moving around, you get a sense that that hyperechoic structure changes shape a little bit. And towards the back end of that imaging, you get a sense that it's actually gone from more of a singular arc to these 3 arcs in a row. And if you think about the shape of our foreign body rotated around into more of a cross section, you can imagine that these kind of hyperechoic signals likely correspond to perhaps the arms body of our foreign body sitting there. Here we have a different case. In this case, we have a 5-year-old male who swallowed a magnet in a much higher stakes clinical situation given the risks of magnet ingestion. Here in the initial view, we have a sagittal view of the gastric antrum. You don't immediately notice anything obvious as far as hyperechoic bodies or reverberation or shadowing, but as we pan through a little bit, you start to notice, you can see there's a small hyperechoic object sitting there, and each time it comes into view, you get this corresponding reverberation artifact in the far field. This was confirmed to be a luckily single magnet within the stomach on X-ray, and this patient was allowed trial of passage of this magnet and had uneventful passage. Here we have a very different foreign body. In this case, this was an 8-month-old male who presented with fussiness. Point-of-care ultrasound was used to evaluate for causes of fussiness, including intussusception and foreign body. On the left, we have a view with the linear transducer placed in a sagittal axis in the epigastric region. And what you start to notice is there is this hypoechoic rounded structure sitting within this region. On the right, we've got a curvilinear view in this same region. And once again, we notice there is a hypoechoic structure sitting in the near field and also a secondary hypoechoic structure sitting down in the far field, as noted by the arrows here. This was ultimately followed up by a radiology study, which confirmed the findings, showing the image here on the left. Here you can see you've got what is likely the gastric body with air. The pylorus sitting here. You've got your rounded forward body that's likely sitting in the duodenal bulb. You've got liver and gallbladder sitting here. This patient ultimately underwent endoscopy and had multiple water beads found, including within the gastric body as well as a duodenal bulb, as you can see right down here. Here we have a different case. This is a 13-year-old female with known history of trichotillomania presenting with abdominal pain. On the left, you can see a gastric ultrasound evaluation showing the gastric body with this hyperechoic structure sitting within it, some shadowing occurring here in the far field. This looks, again, pretty similar to some of our gastric evaluation we showed earlier that could be just full of solid food. Given the patient's history, however, they underwent further evaluation. In this case, they underwent upper GI, and here you can see within the upper GI the contrast within the stomach showing these voids consistent with the hair and this large trichobezoar. Similar case, we have a 3-year-old female with known trichotillomania presenting with emesis. Here we have once again our gastric ultrasound image. Here we have the body of the stomach with this fluid-filled cavity and this hyperechoic structure bouncing around in it. Comparing this to our prior image, however, you can see in this case, this structure, what ultimately ended up being a trichobezoar, does not have the same shadowing that occurred with the prior image. This patient underwent endoscopy and had a large trichobezoar removed. In summary for today's lecture, gastric ultrasound allows for rapid and accurate evaluation and categorization of gastric content and the presence of foreign bodies. Gastric content evaluation is being increasingly used in the perioperative setting to help inform general anesthesia procedural and airway planning. Significant differences in gastric emptying exist in patients requiring emergent versus elective procedures. The utility of gastric content evaluation for pediatric emergency department procedural sedation patients is likely limited to select high-risk patient populations and situations. In line with this, the safety of pediatric procedural sedation is well established, and both the American Academy of Pediatrics and American College of Emergency Physicians support the performance of necessary procedural sedation regardless of fasting time. And lastly, gastric foreign body appearance is dependent on material and orientation, often but not always having associated shadowing and reverberation. Here are the biographies for Dr. Leviter and myself, and here are a few references, and thank you for listening.